True Health Initiative, CEO of Diet ID, Inc., and a board-certified specialist with 30 years of experience in preventive medicine and public health, having trained and later taught at Yale University School of Medicine. Dr. Katz is the founding director of the Yale University's Yale Griffin Prevention Research Center. He received an MD from the Albert Einstein College of Medicine and Master's in Public Health from the Yale University School of Public Health. Dr. Katz.
Senators, I greatly appreciate the privilege of addressing you, the opportunity to share my perspective. I deeply regret doing so without recourse to a professional haircut. If someone had told me I was going to be addressing a committee of the U.S. Senate and doing so sporting my hairdo from 1978, I'm not sure which of those two things I would have found harder to believe, but here we are. I'd like to make 5 quick points about COVID, and I'll quickly note that I'm addressing this primarily as someone schooled in epidemiology, public health, scrutinizing the global data and the data here in the U.S. But I did volunteer in New York, did several shifts in an emergency department in the Bronx. This was part of the Montefiore system, and Dr. Corey, you'll be pleased to hear everything you just mentioned was standard procedure. When I was there 2 weeks ago, it had not been the week before. Steroids were being used routinely, apixaban was being used routinely, and on it goes. So the word is getting out. Whether or not the White House got the memo, others have. So the first point, this is different diseases in different populations. So we heard about the population landing in the hospital, needing intensive care. But the global data clearly show that elderly people and people with a significant burden of prior chronic illness are at high risk of severe COVID infection, life-threatening infection. But the global data showed at the very beginning and appear to show to this day that 98 to 99% of all cases are mild. Younger people, certainly people under 50, maybe under 60, people free of major chronic disease like heart disease, diabetes. This tends to be a relatively mild infection and may often be asymptomatic. Mr. Chairman, you showed us the data out of New York and talked about the fatality rate there. But a seroprevalence study in New York showed that maybe 20% of the population of New York City and perhaps the whole state has already had this infection. That would be 4 million people. And when the denominator swells to that degree, the percent of severe cases drops precipitously. And it's actually quite interesting that 20% is the same number we got from the Diamond Princess cruise ship. And maybe a significant portion of the population is just natively resistant to this bug. But it's different diseases in different populations. There's a high-risk group, elderly, chronically ill. There is a low-risk group, younger, generally healthy. Second point, from the start it's been clear, there were 2 ways for COVID-19 to hurt people, to damage health, to ruin lives. One was by infecting them, but the other basically was the unintended consequences of our interdiction efforts. If we were protecting people who didn't need to be protected from this virus because it wasn't acutely dangerous to them, then causing them to lose their livelihood, putting them in a position of food insecurity, potential poverty, was more likely to hurt them than the virus. I think a humanist, a public health person needs to look at that and say, both ways that this situation can hurt people are bad. And that leads to my third point. We really need to have one national policy objective, and it has nothing to do with trading lives against dollars. That objective is total harm minimization. We acknowledge that people can be hurt by losing their jobs, and that hurt reverberates through public health in something we call social determinants of health. Food insecurity hurts people, desperation hurts people, depression, addiction. We've seen spikes in everything from gun sales to domestic violence to suicides since the advent of this pandemic. And those are real families. Those are real people. All of that warrants our attention, too. And by the way, it's not clear how much of the toll of COVID in New York, in the United States, we mitigated with our interdiction efforts, because we may have closed the barn door after all the horses were out. It seems clear now that COVID was circulating in the United States before we knew about it. We have evidence to suggest from seroprevalence studies that millions and millions of people in New York and around the nation have already been infected. So a lot of what we're seeing may be what we would have seen even with significantly less draconian interdiction efforts. The other thing we want to do, of course, is restore key elements of our society. because those are crucial to services, goods, and supply chains, and ultimately become rate limiting in terms of people's health. We also need to worry about people staying away from the hospital who have other important conditions because of the fear of going where COVID is that Dr. Corey described so beautifully. And then one other critical issue that I think is often overlooked, and that is we do need an all clear. Frankly, I think about people like my parents who are 80 years old. My mother worries that she could get COVID and die because she's in the high risk group at that age. She also worries, though, if we're on an indefinite timeline waiting for a vaccine, that she could die of something else before she ever again gets to hug her grandchildren. So I do think important segments of the population are waiting on a plan back. And the most likely proximal route to an all clear is herd immunity. And that doesn't mean putting people in harm's way. It means risk stratifying the population. So we're able to say who can encounter this infection safely because they're overwhelmingly likely to have a mild bout of it, get over it, make antibodies. And it is fairly clear from the global data. We do make antibodies. We do become immune. There was some communication on that topic that I think was a bit misleading. Point number 4 is we need data to inform a risk stratified approach back to life as we knew it before, protect the vulnerable, but allow many of us who are not prone to severe infection back. And in order to inform a risk stratified approach, 2 things. First, we don't need millions of tests. We need a representative random sample. That could be 20,000 people, 30,000 people, 50,000 people. We could make it a fairly big and robust number. But as long as it traverses urban, suburban, rural, all the different zip codes, all the different age groups, all the different health status, it would be enough to extrapolate to the population of 330 million of us and tell us what we need to know. Who is at risk? Who is likely to be hospitalized? Who might need the ICU? Who's at risk of death? And for whom is the risk of COVID infection commensurate with many other risks associated just with living routinely? And I think that's a critical element. And frankly, this is something CDC does routinely, and it's the work of several days at most a week, and it doesn't require millions of test kits. And then finally, in speaking with colleagues, some of whom are joining as witnesses today, others like Dr. Mike Osterholm at the University of Minnesota, arguably the nation's greatest pandemic response expert, we do need a bracing dose of humility.